Good morning, afternoon, and thank you for joining us for today's VIA VitaFlow in association with you live webinar. My name is Michelle Harrington. I am a registered dietitian on the Medical and Scientific Affairs team with VitaFlow North America. We're excited to bring you this educational activity and introduce our speaker. Today's topic is overview of the nutrition management for pediatric AKI in the intensive care setting. Please note this program is being recorded. Support for this presentation was provided by VitaFlow North America, a Nestle Health Science company. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material herein is accurate as of the date it was presented. It is for educational purposes only and is not intended as a substitute for medical advice. Please note that questions will be addressed following the presentation. However, you are welcome to submit text questions into the Q&A pane at any time during the program. You can access a PDF of the slides by clicking the Slides Handout tab on the left. I have the pleasure of introducing our speaker today. Dr. Molly Wong Vega received her bachelor's degree in nutritional sciences from Texas A&M University and her master's in nutrition from Texas Women's University. She holds specialty certifications in pediatric weight management, pediatrics, and sports nutrition. For the past 15 years, she has worked caring for children with kidney disease at Texas Children's Hospital. She is active in research in several areas, including critical care, nephrology, and malnutrition, and has several publications in pediatric nutrition on continuous renal replacement therapy and malnutrition. She recently completed her doctorate in kinesiology with an emphasis on exercise physiology from the University of Houston. At this time, I'd like to hand it over to Molly.
Thank you, Michelle, for that introduction. So first off, I really have no financial disclosures or conflicts of interest associated with the presentation. Our objective today will be to evaluate the unique components of pediatric nutritional management for acute kidney issues. And then we're going to foster those critical thinking skills and go through a case-based presentation of a patient in an intensive care unit. And then evaluate intake and kind of guide learning on how to manage electrolyte and mineral restrictions for these patients. So in all of my presentations, I always start out with a quick overview of what AKI looks like and what you guys should expect as clinicians. Over the last 20 years, the expectation of what you see is a lot different than previously. AKI is quite prevalent. About 30% of children in an ICU experience AKI, and that incidence increases with longer admissions. For patients who develop AKI, they have a higher risk of mortality in an acute, in an intensive care setting. With stage 3, those that often require a continuous dialytic therapy having the highest mortality rate. So when we talk about epidemiology, previously, people would talk about AKI as it relates to CKD, and then that kind of was that was a thought of these patients have inherent structural abnormalities with their kidneys, but that's not necessarily the case anymore. When we look at AKI now, you see a little bit of a differentiation by age. So younger children, especially infants, may experience sepsis, liver disease, respiratory failure, or require mechanical ventilation. Those are the younger patients that are, older patients greater than a month of age. Apologies. Those are the patients that will experience AKI. And those who are less than a month of age, you usually see AKI associated with cardiac disease, cardiac surgery, or requiring some sort of extracorporeal support like ECMO. And then I really kind of want to discuss a lot about the recovery of AKI. I find that in working with clinicians, especially dietitians, there's this idea that AKI itself is acute because it's in the name, and then once it's done, it's done. And that is really not the case. The other difficulty is that in children who experience AKI, we have to reference different creatinine values to estimate their level of severity. When you are assessing labs, it's not so easy to see an infant whose creatinine has gone from 3 to 6. That's not too different. You know, you can assess that, and it might not even register in your laboratory values when you are looking in your medical record that is substantial, but it actually can be. So this is a nice little graphic of the proposed AKI diagnosis and staging, and then how we kind of look at it over time to see what recovery looks like. And then they really define that recovery is early if it occurs in the first 48 hours, and then it becomes delayed in the first week if there's no recovery there. We then term it acute kidney disease anywhere between 7 to 90 days after that first injury or insult. AKI has 3 stages for the most part. They do have a stage 0, but that's less well reported on and defined, and so you may not necessarily see that clinically. But it's really important to note that it can take up to 90 days to recover from an AKI. Any alterations that you see in kidney function past that, we really start terming chronic kidney disease. And I think that's a piece, especially for your long-term intensive care unit patients, that we kind of forget, because we can have those long-termers. And those long-termers are the ones that are at the most risk nutritionally, where you guys can make a difference. So I talked about that, the epidemiology, but when you look at the literature, the etiology, where a lot of the literature is going, is a shift to an etiology-based definition of AKI. When you look in the literature in AKI and nutrition, whether it's pediatrics or adults, you'll see that, you may find some significant findings in some areas, but in total, it's really hard to define that, because AKI is extremely heterogeneous. You can have a lot of reasons that you develop AKI. And so this model is kind of shifting into more of, you have your staging, but then you can have structural injury, and then you have functional injury. You can have a mix of both, or you can have one or the other. And then that kind of separates how you approach it, or even so, how research occurs. And so this then also helps you understand prognosis, trajectory, and treatment, because you kind of sometimes have to build your nutrition interventions to align with that particular therapy, what you expect to occur, to be the best dietitian that you can to provide the best nutrition. So realistically, your goal as a dietitian in an ICU, from the nutrition therapy standpoint, is really to provide adequate nutrition while avoiding a bunch of metabolic derangements, and then supporting that rehabilitation process that can occur as well. It's, not meant to say that your intervention is going to improve the patient's creatinine. That should never be a goal for you. You are there to support the medical therapies going on. So with that, I'd like to kind of continue into our case study application of the current evidence that we have. A lot of the evidence that we will discuss is reviewed in our guidelines through the Pediatric Renal Nutrition Task Force that we published a couple of years ago. And so I want to point out how you can use these guidelines to then go through your clinical situation of your patients, most especially. This is open access, so you can immediately go search it, download it, and then see how these apply. Okay, so our case study patient, the chief complaint is he's going to be JB, is a 5-week-old infant. He was admitted with hemorrhagic shock and now has stage 3 AKI. So first and foremost, in our clinical practice recommendations of the paper that I'm just alluded to and that you guys can go download, the very first point that we make is that you need to have very good collaboration and communication with all the medical teams. Now, this will vary institution to institution because it will depend on how renal replacement therapy, AKI therapy, is treated and who provides those treatments in your institution. So, for example, at our hospital, Texas Children's Hospital is a very high volume CRRT center. We can have anywhere between no CRRT circuits running, or we can have, I think at max I've seen is 12 circuits running. We have 5 Carpe Diem machines for infant dialysis. This is a ton when you talk about a pediatric center. And so we have our nephrologists do all the prescription. It's a separate group. The ICU does not do the dialytic prescriptions or the AKI therapy, or the intensive care doesn't do really AKI therapy. The pediatric nephrologists always do it. Now, you have to acknowledge that there are other institutions that don't have as large of a group, and they act more of a consult service. And if you have any high level needs, sometimes you can have ICU groups that are prescribing dialytic therapies. So the things that I am kind of going over in this case study are really going to reflect how we provide therapy, because that can change institution to institution based on labor and availability of providers. So in that collaboration, when you look through the text of our clinical practice points, we emphasize collaboration and communication are necessary when we're talking about AKI therapy, fluid balance goals, and lab abnormalities. These should be the first 3 things that you should be assessing in this patient, in addition to your basic nutrition assessment. The types of AKI therapies that can be provided in an ICU. You can do medical management, which is your most conservative. It's kind of a wait and see approach. It's technically can be the most restrictive nutritionally, especially if you have your really advanced stage AKI. But these patients likely have urine output, and that's probably, and no hyperkalemia, and that's probably the main reason these patients don't require it, any kind of renal replacement therapy. But at the same time, as a dietitian, when you're coming into this, you have to acknowledge this is what they're doing. That medical management can include diuretics. It can include a nutrition very conservative restriction from a nutritional intake standpoint. But that is one that is actually, I would say, is the most hard to predict, because you have really no idea of where the patient is going to go, and is usually the one that you have to follow up the most frequently on. The next therapy that I kind of would say is, I go from most conservative and most restrictive nutritionally to least restrictive nutritionally. And so intermittent dialysis therapy, so we're talking about hemodialysis in an acute setting. So like these aren't chronic patients. They don't go to a home dialysis unit, but sometimes in an ICU, you may need to provide some sort of dialytic therapy, but you can't do the continuous dialytic therapies. Oftentimes, their ability to do this therapy is dependent on their cardiovascular stability. If they are not hemodynamically stable, it's less likely that they will tolerate this kind of therapy, because it's a short duration, but it's also quite labor intensive. So you would need somebody manning the machine for a very strict period of time. And sometimes that changes whether or not your facility can do an acute intermittent dialytic therapy. In these ones, what you're looking at is the change between one session to the next. So you're trending it. Usually this is done every couple of days. So you trend it from the end of one treatment to the beginning of the next. How did your labs trend? How did your fluid balance trend? And then you make adjustments from there. And then our least restrictive dialytic therapy when it comes to nutrition is continuous dialysis. Now, technically, peritoneal dialysis can be a continuous dialytic therapy. Oftentimes, this is the patients that you'll see in post-cardiac surgery, where they're just placing a catheter. It's meant to be short-term, and they're doing every hour cycles. This is not frequent in some of your higher care centers for pediatrics, but in some lower resource areas, they may use peritoneal dialysis for this modality. The downside of this is that peritoneal solute removal and fluid removal is less exact than something like continuous renal replacement therapy, as in the veno-venous hemodiafiltration. So you have high clearance with that and high ultrafiltration, and you can kind of titrate it. Basically, I just say it's like turning the knob up or down based on the patient's response. So your patient can change anywhere between these modalities. They can start in one, they can immediately progress to, they can start in medical management, they can immediately progress to continuous dialysis, they can go slow, they can go fast. It changes all the time. And then that changes how you approach the patient. And so you really got to stay on top of these patients if you can. So that's AKI therapies. Now, the instant when we're talking about that collaboration and communication, you need to know and understand fluid balance goals. So I think in most ICU settings, most of those dietitians really do understand fluid balance goals because it's talked about quite a bit. But this resource kind of really gives you a better image graphic of what this looks like, where you have a patient, there's a spectrum of fluid balance, and it can you can have a very fluid overloaded patient. So that could be a post-op cardiac baby. You can have, that can be a nephrotic patient, or you can have a very volume depleted patient who's extremely dehydrated and has gastroenteritis. And so as you provide fluid, your clinical impact, or as you restrict fluid, the clinical impact changes on how important it is for that patient and how fast they can kind of crash or improve. So understanding fluid status is something that I think that a lot of dietitians need to understand, but most especially in the ICU setting. And so when you talk about fluid status, you have to understand, is your team saying the patient is euvolemic, hypovolemic, or hypervolemic? In this case, if the patient is euvolemic, you just think ins equals outs, right? In the ICU setting, you have access to, you should have very good access to accurate ins and outs. And so this should be a little easier for you to titrate and tinker with, to be quite frank. In a hypovolemic patient, what has happened is that patient's in is less than the patient's outs. So that's your gastroenteritis patient who's having a ton of diarrhea. It's just going out, nothing is coming in. So really what the team is going to do is going to want to provide more fluid. So the goal balance for that day or the admission is for a positive fluid balance that gives fluid to rectify the hypovolemic situation. And then you have the opposite for hypervolemia, where the ins are greater than the outs. So maybe the patient's not urinating. And in that instance, the goal balance is negative. You want to remove excess fluid from the patient. Okay. And then that third piece of the collaboration and communication, you really need to assess, are there any laboratory abnormalities in the context of this, the AKI therapy and fluid plan that you need to look at? So the biggest one, and I'll say is always the first one you have to look at, is potassium. It's the one that changes the most, the fastest, and it is the one that really needs to be addressed first and foremost because it can cause cardiac arrhythmias. The one thing that you really have to be careful with is your medical, when you talk about AKI therapies and medical management, you also then have to introduce medications. Medications such as diuretics, if you have a potassium wasting diuretic, this has to, you have to understand this aspect to understand your lab. So if their diuretic therapy is going to bring down their potassium to a low level, maybe the patient doesn't need a potassium restriction. But if your diuretic therapy is not, the patient is on a diuretic therapy and there's no difference in that potassium level, that's something that you need to consider, that if you feed the patient, what you feed the patient, are they going to have hyperkalemia from that? Because again, your goal is metabolic control. In line with medications, I'll also add that in the ICU, you are more likely to have blood products. Potassium, a huge component to potassium intake for some of these patients is packed red blood cells. If your patients require packed red blood cells, they are getting a potassium load. So in that context, you should also be looking at, if your patient has AKI, what their therapy is and how frequently they're requiring packed red blood cells, because that is a potassium load. Oftentimes, if we have to give blood on a patient that requires dialysis, it has to be done with dialysis. So we are cleaning the blood while the patient is getting it so that we can remove the potassium. And then intermittent dialysis, that's where those lab trends take into account to see where did the patient, what was the pre-dialysis potassium, and then what was the trajectory, what happened over time to the next dialysis session. And in between that, you have to be assessing current intake, right? If the patient continued to have high potassium, what was the intake? How do you address your nutrition plan to decrease that high potassium? The next one is going to be phosphorus. This one I would say is a little bit more difficult, but when you're talking about medical management and intermittent hemodialysis, in the context of phosphorus, dialysis is a poor clearer of phosphorus. It's very inefficient. In the chronic setting, it's the number one thing that every dietitian has problems with. And if we solve this problem, we're solving serious world problems. But you're not going to see these things change very frequently. You're going to actually have to be quite restrictive in some cases. And then also acknowledge that medications do play a role, especially your nutrition-related medications play a role in phosphorus management. So if that means that you have to give binders acutely, we do that. If your patient is eating orally, we will give a calcium-based binder or a non-calcium-based binder. Conversely, if your patient is on a continuous modality for dialysis, we have to supplement a lot of phosphorus. Phosphorus is the primary mineral that becomes low in any patient receiving CRRT. This is pediatrics, adults, infants, it's across the board. And in that respect, you should also be looking at dialysate solutions. So when we do continuous renal replacement therapy, a lot of times you can actually manipulate the solutions to provide phosphorus. And again, that also will depend on what your institution uses, what's on formulary, and if they allow that. And then age is a big component in phosphorus. So the younger the child, the higher the phosphorus level I allow, because they really do need it for their bones. There is a limit that we don't really go above, but you all also want to take that into respect and account for that. And then again, you're always looking at intake. How does it change in response to what you're giving? The next one is going to be urea. So how high is too high? This is actually quite dependent based on providers. So I know pediatric nephrologists that will say, 150 is okay as long as it's on the trajectory down. I can also have that same provider say 90 going up on the trajectory from 60 to 90. I have concerns and that's too high. So it's all in context and serially managed. And then you also have to account for endogenous versus exogenous sources. So I recently gave a talk to pediatric nephrologists who and this is related to protein intake, right? Had that discussion of should you delay protein intake, delay dialysis through protein restriction? And there's some cases to be made. But the discussion I provided was based on endogenous versus exogenous sources. If you have a very catabolic patient who immediately presents to the ICU and needs some sort of renal replacement therapy, ask yourself how long that patient has actually gone eating any protein. Then the likelihood, if that urea is very high, it's not highly likely that all this protein intake led to that. And that's important for you to be able to explain that to any of those physicians wanting to do this. And then sodium, we all know it's associated with fluid status, but you also want to take into account age and losses and current intake. There's plenty of times where I see hyponatremia because a patient has been on feeds that are quite low from a sodium intake or don't match how much fluid they get, right? You have to maintain some sort of tonicity when you're giving IV fluids. And it can happen on the opposite way as well. You can give bolus after bolus of normal saline, and that causes hypernatremia. So in our patient JB, 5-week-old, who had hemorrhagic shock and is stage 3 AKI, the ICU asks what you want the feeds to start. So this is day 1 admission. We've looked at AKI therapy, stage 3. So they're just going to actually do medical management, and they're going to give furosemide ×1. Because likely what happens is they're assessing this patient's fluid balance. This patient's fluid balance is actually euvolemic, very little edema, and they actually required fluid resuscitation, although we haven't seen urine output yet. The labs, the patient's potassium after a fluid resuscitation went from 7 to 5.5, creatinine 0.64. Again, this is not super high in an infant, and so just take that into account. It's not like you're seeing an adult where all of a sudden a creatinine of 4, that's equivalent. This patient, the creatinine is sort of low, but it's relative. And then the BUN increased just a bit. Phosphorus came down from 12 to 6. Everybody's happy with these labs. So your assessment details. So the patient was previously breastfed or given expressed human milk. And a little bit of formula. The patient is intubated and sedated. And from a nutrition perspective, your normal weight and height, or weight and length, and a normal Z-score. So you're going to initiate your standard PICU feeding protocol. There's nothing special about this. They're just doing medical management, and nobody's concerned about fluid balance. Breast milk is still best in these patients, even for kidney patients. That is the one that we advocate for no matter what. And then you trend the labs. And again, at this point, fluid balance goal is even. The patient is euvolemic, despite not making any urine output right now. So no fluid restriction is indicated. So our second clinical practice point is to screen and assess these patients as you normally would, but repeated assessments really require higher frequency to reflect your AKI severity, duration, and change in therapies. So trends are always going to be key to interpretation. If it's labs, urine output, tolerance of your AKI therapy, weight trends, because that's going to reflect your fluid balance, and then other alternative methods of anthropometric evaluation. So we know that sometimes you can't get weights in there, but you should really consider other methods of looking at patients to assess them, because again, it depends on your institution, how frequently you get weights, how involved they are in the accuracy of obtaining those weights. So that's, if you ever have concerns, that's where I would go with, is to really evaluate them with other modalities or in line with weights. So by day 4 of admission, well, actually day 3 of admission, JB was transferred out of the PICU. He was looking great. He was spot on. However, day 4 came and he was transferred back to the PICU for spiking creatinine to start continuous veno-venous hemodialysis for 20 hours. The fluid balance for this patient was still, euvolemic. He was just spiking in his labs, namely in creatinine, and the goal was just to be even. So before starting continuous renal replacement therapy, creatinine was 4.8-ish, and it decreased to 1.9. I will say that this lab is meaningless, but I list it here because it's important for you guys to know it's meaningless. After a patient has been on CRRT, you're clearing all kinds of products, and so this level doesn't really mean much for me. BUN decreased in response to initiating CRRT, and then potassium, which was normal, actually became low. Again, in your CRRT is your least restrictive modality because it pulls all the things. It pulls the good things, it pulls the bad things. And phosphorus, which was 8.2 in an infant, I'm actually, especially a 1-month-old, and 8.2, I'm really not concerned about, even in the best of circumstances or worst of circumstances. But however, what you see is once we start CRT, we dropped it low. So assessment details, the patient again made it all the way on higher volume breast milk feeds, but now mom is saying that she doesn't have enough expressed breast milk anymore. The patient is not intubated or sedated. They only required a nasal cannula. Our estimated dry weight has changed a bit, it's down now to 3.9. And the vitals show that the patient is hypertensive, 116/68. I also advocate for dietitians to understand what blood pressures look like and what normal blood pressures are for babies, children, adolescents, because it's not 120/80. And that could be related to AKI itself or fluid status. So what was the plan? We're going to restart feeds. This time, since there's no human milk available, we're going to start a regular infant formula. Why is that? Because we are removing everything. Potassium's low, phosphorus is low. Again, no fluid restriction because we can titrate the ultrafiltration rate in CRRT. And then we're going to continue with the PICU feeding titration protocol. That's the easiest. You're on rounds. You immediately know what to give. You don't have to do any calculations for this. In line with that, treating these patients nutritionally doesn't require a bunch of math initially. You start water-soluble vitamins because dialysis removes a bunch of water-soluble vitamins. So that brings me to our 7th clinical practice point. I've skipped a few. But if your patient receives dialysis, you need to consider what dialysis is removing. So if I'm doing, and I like to say, if I'm doing it in the chronic side, you should be doing it in the acute side. So water-soluble vitamins, especially folate, we start. We also start IV carnitine supplementation because you also experience a lot of amino acid losses, carnitine being one of those. And this is actually also something we tend to provide in our hemo unit. It's not consistent across the board, but it is something that we monitor. So carnitine is something I think that not enough ICU dietitians focus on, particularly in the pediatric side. You may have neonatal dietitians focus on it because there is that recommendation from Aspen regarding a potential deficiency risk and a poor enzyme utilization, especially in infants that are premature and require TPN. However, there's this study out of DC Children's shows that our patients can become carnitine deficient quite quickly on CRRT, with those who have a total carnitine deficiency having that 5 to 6 times higher rate of death. And carnitine is not just an amino acid. It's not like I'm just doing this to provide protein. It is important for cardiac function and lipid tolerance. And when I say cardiac function, we're talking hemodynamics. We can have patients who are carnitine deficient, and the sign of carnitine deficiency is hypotension that is not well treated until you just treat the carnitine deficiency. So what else? Day 4 of admission, day 1 of CRRT. So we're looking now into that clinical practice point 1. We're looking at the AKI therapy. The team has prescribed CRRT, but now you have to look in the medication administration record to see what dialysis solutions they're providing. So they're providing your base solution, which is, the terminology is kind of specific, but BGK 2.0. So that 2 next to the K really means it's a 2 MEQ per liter solution. The 0 means that it has no calcium. And then we do add a little bit of KPhos to help maintain the patient's levels, because again, we already saw the K and the phos were low in this patient. And then they have a normal saline replacement on replacement fluids. This is just a setup thing that you kind of want to acknowledge, and I'll show you why. The patient is also using a citrate-based anticoagulation. So as I kind of mentioned before, phosphorus is a pretty frequent electrolyte abnormality. MAG can be one as well, although I tend not to see it as much, but it definitely can happen, and it gets worse the younger the patient is. So this is where we're talking about starting a regular formula, and sometimes they actually need supplementation. And what I'll refer back to is when you look at Aspen and even ESPN guidelines on supplementation in TPN. Even though I'm not providing TPN on this patient, you can use that as a base because they give you age ranges. So the age range for neonates or infants may be, for phosphorus is 1 to 2 millimoles per kilo. Well, if the patient is that same age on CRT, I'm aiming for the higher range. And that tends to work out okay. But again, you just trend labs. So now when we're talking about this anticoagulation, there are 3 types of anticoagulation commonly used in CRT. Again, these are like all the mechanics, but important for a dietitian to understand. Heparin is usually systemic and frequently used when we're doing tandem ECMO with CRT, but you also have that bleeding risk. So it can be used, but a lot of centers kind of shy away from it. Citrate is regional anticoagulation, so we want that circuit to keep running. We don't want it to just clot and cut off and stop working, because that changes everything about the patient. How frequently, how much fluid the patient needed to have removed. Is this going to change the patient's labs? Are they going to develop hyperkalemia because the circuit's clotted? When you provide citrate, this patient also would require a calcium drip to counteract the citrate to prevent accumulation. It's also important to know that you have to know what citrate concentration your facility utilizes. Most pediatric facilities, if they use citrate, they'll use the dextrose containing solution rather than the non-dextrose containing solution. Most of your adult facilities may tend to go more towards that 4% citrate, no dextrose composition. And I'll show you why this matters in a sec. And then the last up and coming anticoagulation is going to be prostacyclin, historically used to treat pulmonary hypertension, but they're using it more and more in continuous renal replacement therapies. It's short acting, but it kind of takes away the difficulties that people may experience with citrate, which actually ends up being some pretty severe bone growth difficulties. So citrate and the dextrose solutions are calorie-containing fluids, and it's very important for you guys to understand that you may need to treat it kind of like you may propofol, another calorie-containing solution where some people adjust lipid administration if they're getting propofol, right? So when we're talking about this administration of citrate-based anticoagulation, there have been studies done that show that just exposing the patient to this anticoagulation actually increases resting energy expenditure in these patients. Additionally, CRT dose can affect that as well, whether or not it's a high dose or a low dose. And then it also changes how your response to your feeding protocol would occur, right? So if a normal feeding protocol is to start enteral feeds within 2 days and achieve somewhere between 60 and 70% of goal needs by about day 6 to 7, then that means that you may be altering this based on your anticoagulation exposure of calorie-containing fluids. On the flip side, you could have, this is more common in adults, where you have DKA, hyperosmolar states, where you're actually removing more glucose from the patient with CRT. So it's a little different. This graphic that I'm showing you on the left is actually based on adult data that in CRT patients that received the 4% citrate anticoagulation, so no dextrose in their solutions, but they do propose this hypothetical change in what that feeding protocol and bioenergetic need would shift if you have a high amount of citrate, or if your anticoagulation provides quite a bit of dextrose, or if your anticoagulation has no dextrose and your patient is a hyperosmolar, a hyperglycemic state, and you're having to remove a lot of it. So it's just something that you guys should kind of keep in mind. So now on to number 5, clinical practice point, is where we address the energy needs. Energy needs for JB are really based on his clinical condition. AKI has limited effect on that change, except for your exposure to dialysis-related fluids. And again, this is largely only in CRRT. So energy needs, 100 to 120, that's about what we would prescribe our infants. And then it's possible that this patient could have a net gain of calories from citrate and glucose through his anticoagulation. So if I were to look at the size of this patient, look at his eyes and nose, I can see how much of that 2.45% dextrose citrate solution they're getting is about 700 mils. And actually, when you calculate just the dextrose component alone, it's a GIR of like 2 to 3. So in some patients, it's quite a bit. However, it's really a matter of, so what does that mean to you? Are you adjusting how much energy you're providing this infant on CRRT? It depends on how the patient's doing. And to be honest, it's really about the age of the patient when I tend to see this. Clinically, JB was doing fine. Glucoses were fine. And really what you're looking at is the age of the patient. So if you have a younger, smaller patient, that ACDA, I treat more like a bonus. If you have a patient that is older, adult size, those flow rates of anticoagulation from the citrate and the dextrose are extremely high, and this can provide a really high amount of calories. So in the adult world, they may actually completely adjust their calorie provision based on this. So it's, we talk about how we're pediatric centers, but a pediatric dietitian is basically a dietitian for all ages, in my experience. You see premature infants, and then all of a sudden you see a 26-year-old who's very clinically complex, but because the adult world may not be willing to take them. Just kind of things to think about. Caveats with energy need assessment. So you still base your primary PICU guidance on your Schofield equation, BMR, but you really have to reevaluate the longer your CRT duration, and to be honest, the longer your PICU duration. If you're not adjusting your energy needs for time period for which they've been in the ICU setting, you really have to kind of think about that. I find that sometimes they're not adjusted, and we kind of get into what do we do with these chronically critically ill patients? And that's a whole nother thing that I won't address, but start to kind of think about when you adjust energy needs. And it's really based on standard PICU protocols. And the majority of the data that I'm showing you that I talk about is really for treatment times less than 7 days. I have patients that have been on CRT for months. That's not great, but at the same time, it takes months for them to be able to wean off to get to the right place medically to transition them to a different modality. So don't lose sight of those really long-term patients if you have them. All right, so update. JB, day 6 of admission, day 2 of CRRT. So he's still receiving CRRT, but he's not tolerating his advancement of enteral feeds. They've only been able to get him to about 10 mils an hour. And initially he was on a bolus, and then he was reduced to continuous due to GI distress. What I will say is that the information that is available in pediatric ICU patients that have AKI is they are at a higher risk for GI complications. They actually have more feeding intolerance than a lot of the other patients in your ICU. And so for that reason, you have to be very aware of enteral feeding, still the best, but at some point you have to consider where's your line to start something else, some other nutrition support. So you're still kind of assessing what that looks like just nutritionally from your basic PICU nutrition protocol. Labs, phosphorus is low, BUN is undetectable, and creatinine is still high, and potassium on the lower side. So we recommended that this patient start supplemental parenteral nutrition, primarily for protein provision, right? That enteral nutrition is still extremely important from an inflammatory perspective, from infection perspective, and then phos supplementation was started. Let's see, nothing else here. But the other thing I'll kind of talk about is when your BUN is low or a less than sign, it's undetectable. Sometimes, in some cases, we will talk about getting trending BUNs to push the BUN up. It kind of gives us a theoretical way to add more protein, and we'll talk about this in a little bit. But if my patient's BUN is undetectable and I am giving 3 grams per kilo, I may consider giving more because clearly the patient's not utilizing it or needs more. So this is where we get into protein needs, because in the research available, this is what is this is where most of the evidence is, although it's not super great. So by day 6 of admission, day 2 of CRT, we're talking about clinical practice points kind of 4 and 6, modality of feeding and then protein provision. When you think about your modalities, the amount of protein required is on a spectrum. You have intermittent dialysis, manual peritoneal dialysis, which is the peritoneal dialysis that is usually done in an ICU, and then you have continuous renal replacement therapy. So the longer you get on the right side of the spectrum, the more protein you tend to need. Now I've done plenty of talks where we kind of talk about the data, and there's 3 or 4 main pediatric papers that I review. And really all of the data shows all these patients continue in negative protein balances. And so then we kind of still extrapolate from the adult world. And so that's what I'm going to present to you right now is the EFFORT protein trial. That was an international trial of 15 countries, 1,300 randomized patients. And they looked at those who developed AKI. They separated out. So your protocol was high protein versus low protein. And I want to give you a reference for low versus high, right? Like some in the adult world, I'm not sure low is less than 1.2, but this high amount is actually quite high. If we think about the highest protein need in adult patients would be those receiving CRRT, the latest ASPEN guidelines actually only recommends 1.8 grams per kilo, so this is quite high. Their endpoints that they looked at were time to discharge alive, 60-day mortality, and then they did a post hoc analysis of this group of patients who developed this AKI within 7 days of ICU admission. And what they found was overall higher protein intake led to a slower time to discharge alive and a higher 60-day mortality. Now, does this mean we don't give protein or we should cut back how much protein we're giving? This is where your clinical judgment and your ability to read some of these studies is really important to see. This is really good science, but it's in the adults, and you have to kind of then translate to what could that mean for a pediatric patient, and how does your center do dialysis and CRRT, and how did they do it here in this study? So this is your 2 primary graphs that they're looking at with your time to discharge alive for the A, and then your 60-day mortality on the B. And what I want to kind of hone in on are those, when you're looking at your stage 1, 2, and 3, there was really no difference between either of those, but it favored the usual dose, which is that lower protein amount, right? Then in those who actually received some sort of renal replacement therapy, it actually favored the higher dose. And so that's kind of more of the piece in what you need to start kind of asking yourself in this situation on what we're looking at. I'm sorry, if you're dialyzing patient, if you're not dialyzing patient, the way in which that occurs is very different center to center. And especially in the adult world, those with chronic disease or chronic kidney disease actually showed no difference. It was more helpful for those without chronic kidney disease. So taking that into account and how you provide dialysis at your center is important. In these cases, AKI didn't really, the stage of AKI didn't change based on the dose. But if they received renal replacement therapy, there was no difference versus if they did not. So if your patients are getting dialyzed, this was not reflective in the patients that were dialyzed or had chronic kidney disease, is basically what this is showing. So then you kind of look into what you should be, I want to walk you through this paper. And again, it's a really good piece of science, but you have to be able to clinically translate that. And in their methodology, in their conclusion, they said there's no effect on time to discharge alive in patients with AKI who receive dialysis. And so you have to acknowledge that there's going to be differences in how that is performed and when an institution decides to perform that and how they decide to perform it. So nutrition is still important, especially in the setting of continuous renal replacement therapy, even CKD or a very prolonged AKI like this AKD. And then dialysis initiation differs in children, even acutely. So there's definitely more work to do, but I think some larger questions you should kind of have is what's the role of systemic inflammation? How how it is from a chronic perspective. And then when you look, here's the methodology piece. When you look at the methodology of this particular sample, because it was multinational, how do you ensure everybody's doing the same thing all the time? How did they get to, the goal was for them to get to 2.2 grams per kilo of protein per day as soon as possible. Well, in my center, how I would do that is I could do that with TPN. I could do a combination of both, but we still already know, and they report it in the methodology that it's a combination of both. But we still know that in an ICU that this is still your bread and butter PICU protocols. We know that the early versus late parenteral nutrition support or even supplemental parenteral nutrition support in pediatric ICUs has still shown that you could have some more negative outcomes. And it's really associated with the administration of amino acids. Oh my God, what did I do? Oh, I'm really sorry, guys. Okay. So PICU research already supports that you should really limit how much parenteral nutrition you give. But in this instance, I think that this can probably be part of the reason why they see higher mortality and a slower time to discharge alive in these patients, because it's likely that these patients received some sort of IV amino acids sooner than later against basic ICU recommendations. Like this is seen in adults as well. Okay, so now we're going to talk about JB's transition off CRT. So day 9 of admission, day 5 of CRT, we've decreased the duration. So there are certain modalities of CRT that you can perform to slowly decrease duration. So they're daily modalities. And so a decrease in duration means a decrease in clearance. And then what we've seen is this patient became was still euvolemic and started making urine. Labs, the potassium though was still high, creatinine was still high, BUN was normal, phosphorus was still low. And so when we look at our assessment, the patient continued to need to titrate up on regular formula to meet their energy needs. But again, at this point, like I had mentioned before, there was no weight. We needed to find another way to kind of assess and evaluate this patient's nutritional status. So I find that in infants, physical assessment is really good, especially when you're talking about adipose stores and you just look at those legs. Are they chunky infant legs? Is that what you want? And in this instance, you know, if I saw some saggy skin on the infant's legs, then I would say I'm concerned that what the patient has been getting for the last week isn't enough. So as we stop CRT, we can stop the supplemental parenteral nutrition that was primarily for protein. And then in response to this hyperkalemic event, the feeds were held for about 10 hours. And so I needed to find a way to treat this hyperkalemia as we come off circuit. So what do we do when we prepare for these transitions? For the most part, you want to fluid restrict. It's dependent on urine output. And so you want to be more conservative, because what you don't want to do is fluid overload the patient and then make them go immediately back to CRRT. Liberalizing fluids and anything really is easier and faster. And so what I usually recommend is building a plan that is easily modifiable. So you utilize lower renal solute formulas. You can use that in combination with regular formulas just to get the electrolytes at the right spot. And then you have to monitor these patients very closely. Because they can stop CRT, but it doesn't mean they stop all dialytic therapy. It depends on their clinical presentation. Are they hyperkalemic? Are they azotemic? Are they stacking fluid? And that's kind of where you titrate as you go, and goes back to that initial collaboration. So in this instance, the AKI therapy then turned to medical management with a diuretic plan because the patient was making urine. Determining the adequate fluid intake to start with was a little difficult, but what you're really wanting to base that on is urine output. And in order to achieve the even balance on fluid, you really want your outs to equal your ins. So when you're trying to estimate fluid needs for these patients, you are really just calculating what's the max out that they've had recently that they could need. And then that's what I'm basing my nutrition management on. So I calculate insensible losses for this patient. His urine output is about 160. So in total, I can probably give about 300 mils of formula to this patient. And then you have to check the changes daily to monitor urine output. So there is this thing called post-AKI diuresis that can lead to actual hypovolemia and dehydration. It just, like, you can't predict it. The patient just opens up and pees a ton. So the initial nutrition prescription that we gave the ICU was a renal-friendly infant formula at 20 calorie per ounce standard, 300 mils. So there was with procedure changes and coming off circuit, it's like we're restarting the feeding protocol almost over again. We're working our way back up. So there weren't huge changes that we made other than to just watch the trend over time. 300 mils was not at 20 calories per ounce, was not going to meet this patient's calorie levels, but it was still going to be a slow ramp up so that the patient wouldn't receive that much in that short period in a day or two anyway. So we could easily monitor those trends. We stopped the renal multivitamin and the levocarnitine off dialysis. We held phos supplementation. These are the little tweaks that you have to make that often get overlooked. So labs on day 1 after CRT, off CRT, the patient was more hypernatremic. Potassium increased a bit. Phosphorus decreased a little bit, and creatinine pretty much stayed unchanged. BUN stayed unchanged. So what did we do? Fluid balance was negative 100 grams. This correlates back to the hypernatremia that you're seeing and is really the sign that we can actually probably give this patient more fluid. So we increased the formula by about 150 to 200 to meet the patient's energy needs. Now, where would you do if JB's urine output had not increased or his fluid balance had not become negative? You do the opposite of what most nutrition advancement protocols recommend, and you advance concentration over volume. And you concentrate as able, and this is also assessed and reported in our practical guideline. You would do it as you would any other patient, and then you make these daily adjustments. So should JB have been restricted in protein to prevent the start of CRRT? Well, in that consensus paper, we also discussed that we do not decrease protein intake, and I kind of alluded to why we don't do that. For the most part, it's not providing much benefit, and if anything, these patients have really high endogenous production with like catabolism, muscle loss, and that sort of thing. And to be honest, when we were restarting feeds on him after CRT stopping, it's still a slower restart of feeds anyway. They're going to get lower protein. This is assessing the actual intake as well. And then how should JB's electrolytes be managed through his various AKI therapies? I'm going to say that this is extremely difficult to learn, but you won't do it. You won't learn it unless you practice it. And you can chart stock a patient. You can evaluate what the patient gets versus what the patient's labs have done, and then go from there. But this is a really nice table that's provided in our paper that is a very good place to start with, especially with regards to potassium and phosphorus control. And then another point that people sometimes may bring up is, should the vitamin levels or trace elements been evaluated? We don't recommend that you do that. I would say it's not as important when it comes to shorter term duration, and really you should think about it as, what's the patient's primary illness? And then what are your facility standards? Are you even able to provide additional supplementation? And what's the difference in bioavailability in these? You really need to kind of consider what's possible and what's going to kind of muddy the water for some. So when we actually look at some of the adult data in trace elements and vitamin levels in adult CRRT patients in stage 3 AKI compared to non-CRRT patients, so that's the red versus the blue, there's really no substantial difference in the levels that they see from day 0, pre-dialysis, pre-CRRT initiation to day 6. And really what some concerning factors are is the primary illness, and that duration of CRT is really what some concern is. And this is one example of a case report of life-threatening bradycardia and extremely high triglycerides from copper deficiency that was suspected due to CRT losses in a burn patient. And this kind of shows you over time, this patient was on extremely long duration CRT, but also had burns that led to this copper and selenium deficiency that they had to replete in order to reverse the bradycardia and hypertriglyceridemia. But it wasn't one thing that led to, it wasn't the CRT itself that necessarily led to this, but it really did contribute. So this is the last slide. I'm a little short on time, I'm sorry. But JB, 1 month off CRT, he's doing great. But can I transition him off a renal-friendly formula? Probably not. He's getting a version of a renal-friendly formula that's providing about 2 to 2.5 MEQs per kilo. It's not super restrictive, but it's just on the verge. His labs, his K is 5.5. His creatinine is still high. I don't think I can mess with that just to get him on a regular formula. Why would I? And then I would have to add additional medications. And he's also on a handful of other meds. And his weight is not as great as we'd like it to be, and his weight gain since admission is poor. So we're really going to focus on that. So I'm not going to wean him off to a higher potassium formula because that's going to change labs and that's going to introduce other problems. We do see that his weight for age has declined, and we're going to concentrate formula as much as possible with a minimal increase in potassium. At this point, he's 30 days into his AKI event. We need to consider monitoring for some chronic disease things that could have impacted his care. So anemia, renal osteodystrophy should also be considered. So I am sorry, I always go over, guys. I'm sorry.
Molly, thank you. That was fabulous. We are at 2 o'clock, so I just want to let everyone know you can download your CPEU certificate using the tab on the left. You will have to complete a knowledge assessment beforehand. And for those of you who can stay, we're going to go ahead and answer a few questions. So, Molly, our first question comes from Stacy. Any nutrition recommendations for aquapheresis in infants and young children? Specifically, she's looking for kcals per kg, protein per kg, potassium, sodium, phos. And then she said, we recently started Aquadex treatment in NICU as a bridge status post-PD catheter placement. Thank you.
Yes, so we do not use Aquadex at our facility, but what I would, based on what I know about it, it's really primarily, oh, you took it off the screen. So I was to try and make sure I have like all the components to answer. I would do regular calorie needs. I'm not aware of the fluids used that change like a provision of calorie intake. But I think it's primarily for ultrafiltration, so removal of fluids. Aside from that, protein, I don't know that it actually, I don't know how much protein it actually clears, but again, what you can do is, and in the protein recommendations in our CPP, we have a minimum. We recommend the minimum is the DRI, and then you titrate it up to effect. And by technically monitoring your BUN. So if they're getting good clearance, they're gaining weight, and you kind of just see where that max protein is. So in an infant, 1.5 is my minimum, and then we start having discussions if I get asked to go below that. As far as potassium and sodium, I'm going to say that, again, titrate to effect, start at 2, maybe 1 to 2 per kilo on the potassium. For sodium, those infants are going to have higher sodium need. So you may not, sometimes you need restrictions, sometimes you don't. You could start at 3 and see what happens, and then titrate based on intake and level. And then for phosphorus, I can't give you a specific milligram per day, but I would start on the lower end of millimoles per kilo based on the lab. If the lab is normal, I'd probably go with like a 1 millimole per kilo and see what happens. If the lab is high, then maybe a little less and see what happens and watch that trend. I don't know enough about how much clearance Aquadex provides from a solute perspective to be super concrete for you.
Thank you. Do you have a standard dose of carnitine that you recommend?
I do. So that's pretty straightforward. 20 per kilo for anyone on CRRT for the most part until we get to a max of like 500 milligrams total. And then that seems to work out. We've played around with trying to assess levels and track it over time. And inevitably, that number works for us.
Okay, Danielle is wondering, how practical do you think it is to use the equations to estimate calories from CRRT?
It's not practical. Yeah, I don't do it at all. And if anything, the only time, and I don't even calculate the citrate, I just guesstimate it. And I really guesstimate based on only the dextrose, because citrate's a little bit more of a mess to calculate how many calories are from it. But I kind of go based on feel, and just if you have an obese patient that they're concerned is gaining weight, then I might care. If you have a patient that's super hyperglycemic and you're having difficulty controlling their glucose levels and they're already on all the insulin, that might be another indication for you to kind of address things. That's where I would go with that, but I do not calculate that stuff at all.
Okay, Molly,
you probably don't have enough time to begin with.
Yeah. Last question. Is there a pediatric nephrovite that you are aware of?
So in our chronic unit, we will use the adult liquid renal vitamin, which is Nephronex, and then we titrate it down based on age and size. So for an infant, it's usually around 1 ml. I can't recall, maybe once they get to like 5 or 6, it's 2 or 3 mLs, but it's really just titrated. So the full adult dose is, I think, 5 mLs. And so we just titrate it down.
Okay. So I just want to thank Molly again, and thank you to the audience for joining us. We would really appreciate it if you would complete our post-event survey. You should have received a pop-up with the questions, and then you will receive an email with the survey in it in case you didn't get that. We want to let you know if you'd like to come back and join Elisa, Veta, me, and Molly soon. Our advanced PRNA registration is opening any minute. So if you could mark your calendars, it's going to be October 9th through the 11th. And we're delighted to say there will be no charge, and you can get up to 10.25 CPEUs for attending. So thank you again, everyone. I hope you have a fantastic day. Thank you, Molly.